Hi, my name is Al Fillastre. I own Suamorous Dental Lab in Lakeland, Florida, and I'm here today to talk to you a little bit about how to take the mystery out of the machine and make the use of articulators much easier and much more understandable. And I really want my ultimate goal is to teach you how to use articulators practically in your laboratory easily and improve the outcome of your cases. And in particular, I want to talk about the semi-adjustable articulators. We'll compare them. When we take a look at articulators, they have two main purposes in our laboratories. One is functional, obviously, for the movements of the condyle and the mandible. The other is perceptual. It has to do with alignments of teeth to make sure that we keep planes of occlusion the way they're supposed to be in the patient's mouth and don't have surprises with canted occlusal planes when we get our case delivered. Now, I want to talk about function first. And this is, I think, the part that confuses most people when they look at articulators. They don't understand the relationship between the machine and the human skull. Now, the human masticatory system is a remarkably elegant system. Through an interplay of mechanical, geometrical structures in conjunction with muscles, nerves, proprioception, and biofeedback, it allows us to do many things quite eloquently. To chew our food, use our voices, and to interact socially. It's an amazing system. And you know, mastication is what we primarily do. And the entire system is specifically designed to allow the person to efficiently masticate or chew their food, utilizing the anterior teeth for tearing and biting without having the posterior or grinding teeth hit together during chewing in uncomfortable or destructive ways that we call interferences. In other words, to function for many years without destroying itself. So we have to realize there's a harmony that goes on in the human skull between the skull, the joints, the muscles, and the teeth that allow this to function efficiently and without destroying itself. So the question becomes, how do we do this without screwing the whole thing up when we're replacing one or more of these teeth? We want to incorporate it in an existing system that functions very nicely on its own. So when we look at this, there are two systems that work together to accomplish this, and they are quite distinct and separate from each other. They operate independently, but they harmonize with each other. The posterior system, or determinant or component, consists of the condyles, the condylar guidance, the bend angles, the bony structures of the skull. The anterior component consists of the lower anterior teeth riding along the lingual surfaces of the maxillary anterior teeth. Okay? In other words, tooth guidance versus bony guidance. So, working together, they allow us to do the things we want to do. They allow us to do right lateral movements, left lateral movements, protrusive movements, and everything in between that we call all mediocentric movements. So they allow the teeth to move wherever they need to move to accomplish what they need to do, which is to chew and to speak mostly. So let's take a look at how this system works, break it down, and then see how the articulator helps us reproduce that when we make our cases. And how is this system designed in the human skull? What are its components? So the components of the human masticatory system are really two. Okay? We have the skull and we have the mandible. Now, if we look at the skull in particular first, there's two areas we're particularly concerned with. One is the maxilla, obviously, the teeth on the upper jaw. That's the anterior component of occlusion. And the other is a temporal bone, and that houses the posterior components or determinants of occlusion. Now, when we look at the temporal bone in particular, we will get back to the teeth later. There's one area that we are primarily concerned with, and that's this area here, which houses the bony structures that create the fossa in which the condyle, the lower, engages. And the basic anatomy is the glenoid fossa, where the condyle sits in centric relation. The eminence, which is creates the guiding angle. The articular tuberosity, which is the forward stop. Your jaw can't go any farther forward than that. And of course, this bone, this eminence, is at an angle, and we call that the condylar guidance angle. We're all familiar with that, but this is where it really exists in the articulator. And if we look at the upper bow of the articulator, it's designed to mimic that exactly. It has all the same features, they just look a little different. They're a little more, square, but they all represent these parts of the human skull. One main difference is we do tend to set this condylar guidance lower. Instead of 40 to 50 degrees, sometimes 60 in the human skull, we set this between 20 and 30. And there is a reason why we do this, but that we will get back to later. Okay, we'll come back to this, so remember that. Now let's take a look at these structures on the human skull with a little more detail first, and this is the area where we have that glenoid fossa and the anatomy, the bony anatomy that receives the condyle of the mandible. And if we look here, it's hard to tell in 2 dimensions the depth and the heights of here, but these are the places where the fossa, the eminence, and the tuberosity are. The fossa looks like it's a height here, but that's really a depression, and it comes up to the tuberosity towards the camera. And we have a medial wall of the skull there, which creates the bennett angle of about 15 degrees. And the condyle sets in there when we put the lower jaw into place. And it rides in that bony fossa. And again, if we look at the articulator, it's designed exactly the same way, with the same features, the same angles, the same guidance, the same bennett average. So it can allow the lower member to function just like the mandible functions on the human skull. So now let's take a look at the mandible and how it's designed and how it interacts with the skull. The components of the mandible that we are concerned with here are, of course, the condyle, the head of the condyle. That is the posterior component of occlusion of the mandible, and of course the anterior teeth of the teeth of the mandible, and they are the anterior component of occlusion. Again, these are separate but work together. And if we look at the articulator, we'll see that it has 2 condyles in a position that are very similar to where the condyles are relative to the teeth. When we do mount a model, we have something that's anatomically very similar to the human skull. If we take a look at then how the top member fits on the articulator, it represents the skull, and indeed we have a machine that represents quite accurately the geometry, the hard geometry of the human skull. And so we can see how the articulator really is designed a whole lot like the human head, and would allow us to move teeth in a way that's very similar to how they move in the human head. Now, movements of the posterior determinant are probably the ones that are the most complex and the ones that confuse people the most. And I want to spend a little time on how the condyle and glenoid fossa and eminence all play together to produce movements that we can define and we can reproduce. And it is pure geometry. Okay, it's pure, hard, bony geometry. To digress a little and take a look at centric relation, we hear this term all the time, centric relation, we call it CR. And if we look at a definition that says it is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the shapes of the articular eminence in the glenoid fossa. What the heck is that, okay? This is a description that goes way beyond our need in terms of how we can utilize the geometry of the articulator in the lab to produce our cases. It's an overwhelming concept. It's very difficult to really understand. And it's beyond what we need to do. For our purposes here, why don't we define centric as when the articulator is locked in centric and the condyles are up and back in the glenoid fossa. Okay? Without all the anatomy, all the muscles, all the discs, all the ligaments, all the nerves, all that stuff. Just the hard, bony parts of this system, which is what we're mainly concerned with. Okay, so when we start to look at how the condyle moves in that fossa, it's very complex when we consider the entire anatomy. There's so many components to it, so many variables, that it would be practically impossible to actually define and catalog those in a machine that would actually move exactly like the human mandible moves. It's very, very precise and very difficult to do. What we need to do is duplicate the basic geometrical movements so we can have our teeth move in the articulator relative to each other in a way that's very similar to what happens in the skull, so that when we make crowns, they don't screw up the system like we talked about, so that it continues to function in harmony like it's meant to do. And that is what a semi-articulator, semi-adjustable articulator can do for us. Now, these basic movements that occur are simple open and close. We call that a hinge motion. It's protrusive movement, moving the jaw forward. It's lateral, left and right, moving the jaw, lower jaw left and right. And everything in between, what we call the entire envelope of function, is everything in between what we call, these first 3 are called border movements. So simple open and close is really just that. It's with the condyles locked, and the mandible just swings back and forward on an arc. And when we're in the lab, however, we tend to always move the upper member back for convenience. It's the same movement. It's the same arc. It's the same thing. Okay? It's just more convenient to move the upper member, which is not non-physiologic, but it's what we do. Now, these lateral movements that occur are simply the mandible moving to the right side of the jaw, back to center, to the left side, as a left lateral movement. And it looks much like that when it happens. A protrusive is when the two condyles move forward simultaneously and we thrust the lower jaw forward. Now, these movements become much more complex, and there is a lot going on here when we look at this in terms of how it happens in the articulator. And I want you to see here, how similar, how an actual mandible would fit into an articulator. It has the same geometry. But to analyze these movements, I want to use the actual articulator and show what happens when a mandible will drop in a rudimentary mandible with two condyles that fit in the fossa. And we got a right side and a left side. Remember that we're looking from the bottom, so it seems to be reversed. And if we look at these condyles from the side simultaneously, let me pick them up and we'll look from the side also. These condylar balls, looking from the side, will be up and back in that fossa. So we can see the movements from two angles, from the bottom and also from the side. So if we look at the condyle, I want to make sure you understand that these condyles are the same ones in both positions. And we have a condylar guidance that actually moves the condyles down as they would come forward. So if we look at a right lateral movement, let's dissect it and look at it slowly and see what it does. In a right lateral movement, the right condyle, the working condyle, doesn't go anywhere. It just rotates around an axis. It doesn't move. But the non-working condyle, also known as a translating condyle, moves down the fossa. And if we look, as that translating condyle has moved forward, it has also moved down. And this is what kind of helps separate our posterior teeth as we go into protrusion, which is part of our chewing motion. Okay, if we bring this back, we notice that the non-working or balancing condyle moves back, but the working condyle simply rotates back into the starting position. It doesn't go anywhere, it doesn't move. And this is a very important concept to understand later on when we look at how to analyze occlusal problems or functional problems. If we look at a left lateral movement, again, it's exactly the same thing, just the opposite. The working condyle, which is the left side condyle, rotates as the translating or balancing condyle comes forward, and as it moves forward, the other condyle, the condyle actually drops down in the fossa. So the forward movement also causes the condyle to drop down. And in protrusive movement, both condyles move forward simultaneously. But this is where the Bennett movement comes into play, because there is an angle to the Bennett component, which is at 15 degrees. It allows the condyles, when we are in protrusion, to actually move back and forth and have a back and forth movement. In centric, they cannot move back and forth, but as we come forward, they can. And this is also something that's very important to keep in mind when we're designing our cases. Now, if we look at all these movements together, which we call mediotrusive, the condyles can move in what ends up being a triangular pattern. And they can also move anywhere along that eminence down to the articular tuberosity. They can move forward and down, side to side as they come forward. And this creates what we've known to be the envelope of function, which you can see here, which is almost a triangular area in which the condyle can occupy any of that space. So let's look at the posterior component movements and how they work relative to the teeth. And for that, we'll use just a model here that takes a look. What we've got is a articulator set up with a 10-degree condylar guidance. We've got a mandible and maxilla set up with no teeth on them at this point. Okay, we have no teeth yet. We're just going to look at this movement. And if you look, because the maxilla is angled down at about 10 degrees, the guidance is at 10 degrees, this just moves. It's like a sliding motion. The teeth are sliding along each other the whole way, and this would be nothing but continual interferences. So now let's look at the same system, but increase the guidance to 30. Now remember, in the human skull, the guidance is closer to 50, sometimes 60, as high as 60. Between 40 and 60 is considered anatomical average. If we then move that mandible, we did get a little tiny bit of posterior disclusion, but not much. Little bit. The posterior teeth came apart a little bit. So if we increase it higher, we get a little bit more, but not enough to clear the posterior teeth when we're chewing our food. We'd still have nothing but interferences in this area here. So let's make this more realistic and add a tooth now. We're going to add an anterior tooth. But let's take the condylar guidance back to 10 degrees. Let's make it real shallow again, back to where we were, but now we've got a tooth in the front. When we move this forward, look what happens. The lower incisor edge rides along the lingual of that upper tooth, and it causes a whole lot more disclusion. It's still not a ton in the back, but way more than what we had before. Remember, we're very flat. We're only at 10 degrees. If we take this back and change this guidance now to a little more physiologic number, 30 degrees, and take a look, look what happens. We separate the teeth almost parallel to each other as we come forward. This is what needs to happen in the human skull when we're chewing to protect our posterior teeth from interferences and from destroying themselves as we chew and move our lower jaw. So we want to have plenty of exclusion to make sure that we have no interferences. So if we increase anterior guidance, make a steeper tooth or a longer or steeper tooth, it's interesting what happens. When we keep the articulator 30 degrees and look at this movement, notice that in the posterior it didn't exclude as much. Okay, wow, what? I mean, we have a steeper tooth. Why is the exclusion less in this area here? The answer is because, let's take a look at these two examples and look at the one with the short tooth and the steeper tooth, and look at this posterior disclusion both there and there. And what you'll see is that because we have what is a locked-in bite in the steep anterior guidance, the mandible cannot come as far forward. It can't come down the eminence as far, therefore it can't separate the posterior teeth as much. So when we have steep locked-in guidance, we have to remember we have to be more conscious of the posterior cusp, because this physically, geometrically cannot separate as much in function. Okay, it's limited by those teeth, by the steep linguals of the anterior teeth. An important concept to keep in mind. So now let's shift our thought to the actual teeth themselves and how they function relative to each other. And remember, this is independent of the condylar guidance, and I'll show you an example of that so you understand that more clearly. But the anterior determinant of occlusion is the lower incisors riding up and along the lingual inclines of the upper incisors. Okay, what we call incisal guidance. Okay, and it allows us, and it, like I said, is independent of the posterior guidance, what we just looked at. And here's an example to explain that. Let's just say that this arc here is, which is my hose holder, is the eminence. It's the lingual surface of the upper teeth, and the rake is the lower incisors. Okay, and as we move that along, notice that the lower incisors ride along the arc of the linguals of the upper teeth. And we have a certain angle of this handle, which would be the guidance angle, okay, coming from the skull. It's whatever it is, 40 degrees, 50 degrees, whatever it is. Okay, if we lower that angle and then do the same movement, you notice that even though the guidance is much lower, the actual teeth represented by the rake still ride along that arc in exactly the same way. They start at the bottom, they ride up to the top. Nothing changes. I can pick that handle up or down. It's not going to change the way those teeth move across each other. Whether it's higher or lower, the incisal guidance remains the same. It follows the same path. Okay? So indeed, the two components, although they work together, are completely separate. Okay, so now that we understand, at least hopefully a little bit, how these components are designed and how they function, let's look at how the teeth are actually arranged in the human skull, and consequently how we will arrange them in the articulator. So for this, let's take a look at the skull, and we have two really ways that we look at it. One is from the front view, what's the side-to-side orientation or the cant of the maxilla, and therefore the mandible. And we use a horizontal plane to determine that, and you know the teeth should be parallel to the horizontal axis of the skull, which from the front is the interocular line. We use that to determine what the horizontal axis should be. We'll use the pupils of the eye in the real patient. Now from the side view, we can see how much we can have a vertical axis, a horizontal axis, and that will allow us to determine how much front to back or tilt there is to the teeth. Okay, and if we look at a normal maxilla, the average will be a 10-degree tilt from the vertical axis. And so when we go further and dissect this from the glenoid fossa down to the incisal edge of the maxilla of the maxillary central is on average 110 millimeters, and it's at a down angle of 26 degrees from the condyle. And again, which is very interesting, the average intercondylar width is also 110 millimeters. So we have an equilateral triangle between the condyles and then forward to the maxillary central of 110 millimeters on all sides. And that's known as the Bonwell triangle, which we'll talk about a little bit later. And so we notice when we look at the actual teeth, though, and put the mandible back into place, that the teeth themselves are at a down angle or a back to front tilt of 10 degrees average. And again, you know, and the teeth do bisect directly from the Frankfurt horizontal plane to the bottom of the chin. It's equilateral. Now, all these numbers are averages. You know, they're based on studies that were done. They're based on looking at thousands of skulls, and they vary a little bit depending on whose book you might read or what a particular researcher found when he did it. But these are pretty solid numbers and pretty well agreed upon in the dental community. So, how do we get the teeth into the articulator? The same way that they are arranged in the patient's head. And we have two ways to do that. One is with a Facebow, and the other is with an arbitrary mounting platform. And, you know, again, we have these two methods. You know, which one do we use? And the answer is what we're trying to do. Now, the DNR mounting platform is a really awesome tool. We use this probably in 90% of our maxillary restorative cases. It's designed around all these averages that we just talked about on the skull. It's meant to mimic all these averages. It's vertically centered between the upper and lower members. It's 110 millimeters from the condyle to the maxillary incisor, just like the average skull. It's at a 10-degree down tilt from the vertical. It conforms to the Bonwell triangle, equilateral triangle of 110 millimeters on all three sides between the condyles and then down forward to the maxillary incisor, and allows us to place a maxillary cast in an anatomically average place in the articulator so it functions like an anatomically average maxilla would in a skull. Now, if we look at the platform versus the Facebow, there are distinct criteria that will determine when we use one or the other. Okay, and I'll start with the Facebow. Now, for sure, it's almost always an anterior case that we're doing when we need a Facebow. The primary distinction here is that it's a case that requires corrective measures, requires a diagnostic procedure. There's a problem with the occlusal plane or the function or something going on that requires us to correct an occlusal plane issue. So the process we would go through would be for the doctor to provide us with this Facebow, the photos, the models, the impressions, whatever it is we need to be able to get these casts created and mounted and then correct the problem, which in this case was a slanting occlusal plane off to the patient's left. So we do a diagnostic wax up of this. And the reason the Facebow is so important is that in order for me, the technician, to correct this, we have to have that side-to-side cant visible in the articulator. If the teeth are straight, we can't correct it. We have to see the problem on the articulator. A Facebow is needed to actually capture a cant or a tilt that is not straight. Okay? So we now make our clinical proposal, and that can go back to the doctor and make the temps. Sometimes we have to pause and do something more aggressive, maybe some surgery to reposition a maxilla, maybe some orthodontics if we can't just shape a tooth that's too far out of position to be able to just fix it with crowns. If that's necessary, that step will be done first, and then we would come back to the temporaries. In any event, using the articulator, we correct the occlusal plane problem that was the primary complaint of the patient to begin with. Once we have the temps, the patient wears them, the doctor and patient accept what they see, maybe some minor changes are made, and once the patient goes, yes, we like that, now we can start the restorative part, starting with the capturing of the study model of those temps as they've been changed or modified in the patient's head to function absolutely perfectly. And from there, we could take the study model now and go to the mounting platform. When that case comes back, now everything is straight. We don't need to capture a problem. We just need to position that thing in the articulator, that upper cast, in an anatomically close position. We can then use our aesthetic controls, our guide tables, our matrices, the things we use to get control over what we're doing. So when we get back to the mouth, we have no surprises. We make the teeth on the articulator. They're lined up perfectly horizontally and vertically. And when they go to the mouth, they line up horizontally and vertically. And everything is controlled right down the line so that when we get to the mouth, there are no surprises. Now, with the platform, typically when we would choose to use this is when we don't need a correction for this case. Okay, the patient's teeth are already in nice alignment. We're going to make some minor changes and make them a little more perfect when we do the crowns, but we don't have any occlusal plane issues to correct. So now we can go directly from the study model to the mounting platform and get it straight in the articulator, produce our aesthetic controls, go back and produce our crowns, exactly horizontal, exactly vertical in the midline to the articulator, and then we have a completed case that goes to the mouth and no surprises. And again, just to be, at the risk of being too redundant, to make it really simple, platform, if no correction is necessary on an anterior case, the occlusal plane is good. We go right through to the completed case, keeping everything square on the articulator. We use a Facebow when we got to capture a problem, a canted occlusal plane. We want to correct it with a wax up, make temps, and go to finals. Okay, that's the main difference. And Facebows, trust me, are not always so great. I work with great dentists, and we see something like this quite often. Did he not center it when he adjusted when he got it in the ear bow? Was there a problem there? Did this thing move in the male? What happened with this case? I don't know, okay? But it shifted off to the patient's left. And now things are not centered in the articulator. And I may call the doctor to ask, hey, was this patient in a round? Was there some reason? Are these totally asymmetrical? Chances are no. And on top of that, this case, we are not trying to correct any occlusal plane issues. We're trying to make some crowns that are going to be basically in the same position these teeth are when we started. And if I put this cast on the on a platform, you can see how far off it is to the patient's left. Okay, it's not centered. Now, when we looked at it from the side, it was interesting that the 10-degree down tilt, which is pretty average and pretty consistent, was there. It was just shifted to the patient's left. There was not a tilt problem. And the incisors came just about to the 110 millimeter line. Okay, so we're really close to the anatomical average. We're just not square in the articulator. So we chose not to use the Facebow in this case, put it on the mounting platform, and get it square in the articulator. Now I got a case that's centered vertically. It's parallel horizontally. When I make my teeth, now my articulator is my friend because my vertical axis and my horizontal axis match the articulator. So if we go back to the teeth now and look at how the guidance functions in the mouth, how do we use what we've learned so far to help us avoid problems when we're actually doing a case? If you remember, the anterior guidance separates the posterior teeth. The anterior guidance separates the posterior teeth. The posterior or condylar guidance determines how much they separate. Okay? Remember when we had no teeth, they just slid across each other, nothing separated, or very, very little. And once we added a tooth, now the posteriors separate. How much? That's determined by the guidance. So it's important for us to understand that we need to harmonize these things so that the delicate biters or anterior teeth, which are very delicate, they move the powerful chewers out of the way because your posterior teeth are attached to big, powerful muscles, the masseter muscles of mastication. They have a lot of force and they can really cause some damage. So you want these delicate teeth to make sure those are separated and don't destroy themselves. Now, the system is completely brilliant. The way it's designed is remarkable because the posterior teeth, when it functions properly, separate just as soon as the mandible moves. And if this fails to happen, we have what we're talking about, interferences, and they are painful and destructive. They can break teeth, they can cause joint problems, headaches, night grinding, pain. Interferences are deadly, and the whole system is designed to avoid this. And if we, so remember, we set articulators to 25 degrees. Remember, we talked about how we set them at a lower guidance than most average skulls are. We set them at 25 to 30, depending on how you particularly feel about this. The skull is more like 40 to 60, okay? And why do we do this? Remember, the human skull is more like 50. If we look at an articulator set at 50 versus one set at 25, you can see how much farther the posterior teeth are separated just by changing the condylar guidance, keeping the anterior guidance the same. Now, if we look at the implication of this on a tooth, okay, at 25 degrees, the the teeth separate at an angle of 25 degrees, which means we can have cusp fossa angles, the angle from a fossa up to the tip of a cusp of 25 degrees, and avoid any kind of interference. If the conjugate guidance is 50 degrees, we can steepen that. We could steepen those cusps, make the anatomy more robust, make the cusp fossa wall angles steeper, make everything more rugged on that occlusal. But when we do that, we increase the chance of having interferences because teeth would have to move apart quicker to avoid hitting each other as they move sideways because the mountain peaks are steeper, okay? Now, also when we increase conjugate guidance and increase the steepness of the cusp, we enhance mastication efficiency. People chew better. So we're looking at a balance. If we set conjugate guidance at 0, we'd have flat teeth. They wouldn't chew very well. If we set them at 50, we have a chance of having interferences which are destructive. So we kind of split the difference. We go 25, and we get enough disclusion to give us nice occlusal chewing efficiency, good anatomy, good function, without running the risk or really lowering the risk of having interferences. So what we want to do is balance out these two things between pretty efficiently masticating teeth and ones that avoid each other and don't cause problems and aren't too flat. So, you know, it's very important to remember that increasing conjugate guidance separates the posterior teeth quicker when we're talking about protrusion and on the balancing side. Now, I'm going back to what we talked about the mandible moving. Remember, on the working side, the condyle does not move. It rotates. So you don't get the posterior component. You don't get disclusion because the condyle is not coming down that eminence. It's not going anywhere. Okay? So on the working side, it doesn't matter how steep the guidance is, the posterior teeth are not going to separate any faster. You can put it on 0, you can put it on 60, and it's going to be exactly the same. But on protrusion and on the balancing side, the conjugate guidance does affect how quick the posterior teeth separate. Okay, remember, the working condyle doesn't move. It spins in the fossa. It just rotates. Okay, the balancing condyle translates. It moves down that eminence. Okay, remember when we saw this, the working condyle spins, the balancing condyle moves forward and down, which separates the posterior teeth. Okay, so only on the balancing side. So how can we determine more closely what the conjugate guidance angle is for a given patient? Okay, and where do we set it? Well, we're going to set it to the lowest number that eliminates any balancing interferences. Okay, those are the most destructive ones, and those are the ones on the opposite side of the mouth from which the mandible moves. So if we move the mandible to the right, the left side will have the balancing interferences, and vice versa. And so in the posterior, we want to see separation on that side whenever the mandible moves. So why do we pick the lowest number? Remember this? Okay, we want to have some cusp fossa wall angles so the teeth will chew, but the lowest number that will allow us to get past, okay, to let the molars pass each other without hitting, to avoid any chance that our crown or crowns will have these interferences in the mouth, or we're going to have problems. So we can either set the articulator by visually looking at the teeth to see what setting causes the posteriors to not touch on a balancing side, or we can use protrusive bites if the doctor gives them to us. Now first, let me look at just looking at casts, because this is what we do 99.99% of the time. I get protrusive bites rarely, but I'm going to touch on them so you understand how to use them should you get them. You have to do this prior to making a guide table. This is essential because if you have a balancing interference, you're not going to get an accurate guide table. So we take the models, we go into a lateral movement. In this case, we're going into a right lateral movement. And look back here, the teeth are indeed separated, okay? And they're separated in the cuspid area, in the bicuspid area. They're separated in the anterior. Matter of fact, they're separated all the way around, all the way back to there. There's nothing touching. Right now, this is a warning sign. And look, particularly here, okay, we should have cuspid guided occlusion when we go into a lateral movement, and the cuspids aren't even touching. We could not make a guide table here because the guide table is what captures the function of the lower teeth against the upper cuspids and upper anteriors. What is pulling these teeth apart? Okay? And this is the reason why we have to have a good study model before we start anterior cases so we can see these things. Okay, what we've got, if we look on that patient's left side, look way back there, we have a huge balancing interference. Okay, it is so big that it is causing all the teeth forward of that, all the way around that arch, to separate from each other. And none of the true function of what this patient has, which is anterior guidance, comes into play. There is no anterior guidance here. It's all being done by this. If we were sort of patient like this, they would be in so much pain they would loosen and destroy those teeth. We know that's not happening, so what we know is this patient's condylar guidance must be steeper than 25. Okay, so when we take the articulator and move the condyles now up to a higher number, I'm going to go all the way up to 60 just to really see what happens. Okay, I'll start on the high end. Let's come back now and go into a lateral movement and take a look at what that did. Look, now our cuspid is in guidance. Our posteriors are discluded on the working side. Okay, we have disclusion back there. Even our centrals are now coming into play. They are harmonizing with the cuspids in helping with the anterior guidance. And if we look back there now, the teeth separate. Okay. The only difference we made was we went from 25 to 60 degrees on the condylar setting. Now, this amount of disclusion here is, for example, only if I saw this, I would drop the condyles back to 50. I would drop them back to a number that just let these things clear and allowed my cuspids to still touch on the working side, okay, when I'm in function. So this is sweet. Now I've got my anterior component truly functioning. Before we didn't. There was no anterior component. The condylar guidance was too low for this patient. So this is the reason why I'm a big proponent of semi-adjustable articulators that have an adjustable condylar guidance, because if we didn't have that, we could not do this case. If we had a fixed condylar guidance, we could not adjust out this balancing interference, and what we did for this patient would be inaccurate. We would make too steep of an anterior guidance, and it would be a problem for the patient. Now, protrusive bites are really cool, but they're not as easy as they look to really use. But here's the idea, okay, of what protrusive bites do. If we take a patient that's got a 25-degree condylar guidance on their eminence, and we look at how much the posterior separate, it's that amount. If they have a 60-degree, that same patient is going to separate by a whole lot more in the posterior. Okay, remember, the anterior teeth disclude the posteriors. The condylar guidance determines how much they disclude. So if we put a bite in there, let's say this patient really was at 60, and so the doctor puts a bite in, that space that's back there, he moves the patient forward in protrusion, holds them there, puts bite material in, takes a bite, okay? Now let's say he delivers us that bite, and we put the cast in the articulator, we try to put that bite into place, it won't fit, because we have our articulator set at 25. It's not far enough apart, the bite won't go to place. So what we can do is increase condylar guidance until it does. Okay. Now we have the condylar guidance on our machine, the same as the patient. And the protrusive bite showed us how far apart those posterior teeth were, which is a function of condylar guidance. Remember, it's independent of anterior guidance. The two things work together, but they're separate from each other. If you guys get anything out of all this, that's one of the key concepts I'd like you to get. So if we took that bite and put it in the mouth where we had the condylar guidance too low, you can see that because it's too high in the back, it holds the anterior open. Okay, we can't bite. It can't get that fronts closed. There's too much stuff in the back, and so we take the condylar guidance, we increase it, kind of like this, and and when we put this to place, suddenly the bite fits. Okay, so you can actually rock the condyles forward, roll them to a higher degree until you see the bite slowly come into where it fits all the way back. Now, if instead we have our condylar guidance set too high and the patient is actually lower and we have protrusive, we'll see just the opposite. We'll see that the posterior is still open because the anterior is hitting too soon. Okay, we need to bring down the posterior. It wasn't able to disclude as fast because the patient's guidance is actually less than our machine. So in a case like this, we would lower the condylar guidance until the bites fit. So me personally, I prefer just to look at study casts and adjust condylar guidance until balancing interferences are removed. And again, we have to do this prior to making a guide table to capture our anterior guidance, or it will be inaccurate and we will make a case with far too steep of a guidance. Okay. And we only make an anterior guide table if the anterior teeth that provide guidance are being restored. You know, quite often if we're doing 7 to 10 and we look, the cuspids are guiding in lateral, they're guiding in protrusion, we might even have group function on a first bicuspid, and we notice, hey, you know, all of our anterior guidance is provided by teeth that aren't prepared. You always have to look. Just because we're doing lateral to lateral doesn't mean that we're missing an anterior component. We might not be. Other teeth could be providing it, and we don't need a guide table. Okay? Other times, we may be doing just one central and realize the other central is facially displaced or whatever. The laterals are short, and maybe that one central is providing protrusive guidance. Maybe it was. And we need to be aware of that, because if it was, we need to now make a guide table to capture that before we restore the case. Or we'll make their guidance wrong. We'll put teeth into function that weren't into function. So the anterior guide table, that's all it does. It just captures a pantograph or a tracing of how that moves, how the models move, based on how the anterior teeth are right across each other, okay? Which means, you know, whenever we do this, we have to have very accurate study models. This is a very important thing, that we capture what I call the hard envelope of function, that we capture the pantograph of how those teeth function across each other. And so when we look at a finished guide table, what it represents is the steepness of the maxillary linguals. Remember, and it's independent of conjugal guidance. If you change conjugal guidance and increase it or decreased it, this pantograph would look exactly the same. Remember the rake going across the hose holder, same idea. This is the rake and the hose holder is what we're making here. Okay, so that area down in there represents the envelope of function of the patient. And this is one thing Danar brings to the table. And you know, years ago, you know, when we worked with Danar before Whitmix acquired them, we actually developed this pen. And we were trying to come up with a pen that didn't get it in its own way when we were making these guide tables. And as we hollowed it out from the lingual, as we tapered it down, as we shaped it so it would give us a clear tracking of this pantograph, we realized, lo and behold, we had created the same profile as the maxillary central, which is kind of interesting, you know. And as far as I know, Danar is the only company that makes this anterior determiner pen that allows you to make really accurate, precisely tracking guide tables. Okay, now I would like to compare the functionality of a semi-adjustable articulator to straight line or hinge or plastic, whatever you want to call the various articulators that we traditionally use in laboratories for our smaller cases and sometimes for our bigger cases, and look at some of the problems they can cause because of the placement of the condyles relative to the teeth. They're so non-anatomic and so out of the average positioning that they cause the teeth to move in ways that are not physiologic and can cause problems. And I'd really like to point some of that out, starting with what we call the arc of closure, or the hinge axis of the teeth based on condylar position. So if we look at an anatomically correct articulator, a semi-adjustable, and we look at the arc that's caused between the teeth and the condyle, it scribes a circle like this, okay, that has moves downward and backward as the lower jaw opens. If we put a metal, what I call a barn hinge articulator in place and look at its arc, okay, compared to the one of the articulator, notice that on the downside that it actually moves more forward. As the mandible drops down, it's actually more forward of where it should be. The green line being this metal articulator versus the orange line, which is a semi-adjustable, moving backward quicker. And if we look at a plastic articulator, an Orbix articulator here, which has an even lower condylar position, the arc moves that model even farther forward than moves lower forward. So if we look at those three, the yellow being the articulator, the green being the hinge, the orange being the plastic, then you can see that we progressively move the mandible more forward as it hinges downward or closes in an upward movement. And so, you know, getting the proper arc is really critical at certain times. Sometimes it's not so critical, but it influences to a great extent how these teeth function, how they move. To give an example of this, especially when we're opening vertical, if we take a cast and just arbitrarily open vertical by putting a pad on the two bicuspids and looking at what happens on the articulator when we open vertical, the teeth contact more towards the middle of the tooth. If we change this to a plastic articulator, you can see how much farther forward towards the mesial marginal ridges the actual opposing teeth contact. If we look at those two marks, that is a substantial anterior-posterior discrepancy between the articulator, which remember moves posteriorly faster as you open it, versus the plastic or the metal articulator, which moves more forward as you open it. So it moves our contact points significantly forward to the tune of maybe 2 millimeters in this case. Now imagine producing a case that has that much of a discrepancy in when the contacts are between what you did on the articulator and what happens in the mouth. When you get to the anterior teeth, the doctor would be ruining your crowns trying to get this to close because all your contacts would be way too far forward. They'd be pushed into the linguals of the upper anterior teeth instead of back on the cingulums. And you'd have a huge, huge problem. Now this really is important when we're doing dentures and doing full arch cases. Because on full arch cases, we tend to customarily adjust the vertical based on what we need to make the teeth right. And we quite often open them a little bit to give ourselves the room that we need. On dentures, we open them almost indiscriminately. And so in those two situations, getting a Facebow is a really good idea to get us on the hinge axis, or mount them with the mounting platform. Get ourselves at least in a physiologically average or close to the patient position. Now, that's critical. That's very important when we talk about the arc of closure or the arc of opening just by the hinge axis, the articulator. But this actually worries me a little bit more, and this is what happens when we go into lateral, and that's how you function. Okay, opening and closing, people don't do that much. When you chew, you're using your entire envelope of function. But if we look at the lateral movement, it's remarkable what the differences that occur between these two types of articulators. So if I just mark a position on the cuspid and mark the condyles, to record their positions, okay, I can see where that would be relative to those same positions using a plastic articulator. And so there's where the condyle will be relative to that cuspid on a plastic articulator. If we now scribe the arc that the mandible would move when we go laterally, okay, the green line representing the plastic articulator, okay, and then the yellow line representing the articulator, look at the difference in the path that those teeth take as they move laterally. Look how much quicker backwards in lateral movement the plastic articulator moves. Remember, it moves more forward in hinging, but in lateral movement, it moves backwards far too quickly. And that's the way the teeth would come across each other, okay? The articulator versus the straight line or the hinge or the plastic, whatever you want to call it. And so if we look how this translates into actually designing a case, we'll just take a 3-unit posterior case involving 2 bicuspids and a molar. And if we go into a lateral movement on the articulator, you can see that the second bicuspid and first bicuspid are actually almost touching the tips of those lower bicuspids as we go to lateral. We almost have interference, not quite. We just got rid of it. It's almost a group function situation. On the hinge, look how much further those cusps are apart. Not to mention that, let's look at one point on the very distal corner of this cuspid, and you'll see how much farther forward the teeth are on the hinge articulator, and it causes our teeth to move across each other in ways that would cause us to create problems. Looking at this lower, I would look at that space there, and this curve is actually a little bit reversed. A really good speed curve would bring those incisal cusps of the bicuspids down a little bit, especially the second one. And on that plastic articulator, I would look at that and go, oh, I can do this. Let me build them a porcelain there and bring those down. But we can see from the articulator that if I did that, I would create interference in the mouth. Okay? So it will cause me to think I have a situation in lateral function that's not what's going to happen in the patient's mouth. And it would cause me, in this case, to create interference, a working interference in this case, on this patient. So, if we take these ideas and take them one step further into using quadrant models, one of the problems is that, quadrant models don't provide one half of the arch. They don't provide balancing disclusion, okay? When the mandible, in this case, moves to the patient's left, we're not going to have any balancing interference. Now, I do mount quadrants occasionally on articulators, but only when I have no teeth behind the prep and I want to have support back there so it doesn't collapse
Plastic articulators tend to not be very accurate in situations like this. But be very careful with quadrant models, okay? Because you have, like I said, no anterior component in the balancing movement. In other words, when the mandible moves that way, there's no teeth on that side to provide a balancing function on the anterior. There's no way to do that. So here's an example of how this can translate into issues that when we're making a crown. We're going to look at this gold crown on this maxillary second molar. Okay, and the first thing I'm going to do is just look at their occlusion. And when I do, I notice that I do have some balancing interferences. Notice those are marks on the lingual inclines of the upper teeth. That's where you see balancing interferences. Okay, that's when the mandible moves across, the working movements on the other side. The lower cusps move across that incline, and they create interferences. We can see them there with the red tape. So that's at a 25-degree guidance. We got balancing interferences. What do we do with this? We should increase our guidance slightly because we know the patient most likely doesn't have this because they typically create problems. They typically create headaches, joint problems. They're uncomfortable. Balancing interferences are very uncomfortable. So I went up to 60-degree guidance, and notice what happened was we eliminated that one, okay? But we still have a slight balancing interference on the second bicuspid. Those two marks are the centric stops. We want the cusp tip and the fossa, but we don't want in between. We don't want a slide in between. We still have that little balancing interference on the second bicuspid, which if I'm at 60 degrees and I see that, my guess is the patient is living with that and they're okay. They've adapted to that and they have that in their mouth. Okay, so my analysis of this is the patient does have a small balancing interference on that second bi, or their guidance is steeper than 60, which is unlikely. And so this is something the doctor hasn't detected yet. He probably should adjust that out in the patient's mouth. Okay, that small balancing interference. Now, let's remove the anterior component on the balancing side. Okay, let's do that. And what we'll see here is that we have now the same situation as a quadrant articulator. Okay, and what we're going to see here is what always happens with quadrants. Okay, so when we do this and we still have our condyle set at 60 degrees and we have no component from the balancing side, no posterior component, notice that we right back to severe balancing interferences on those lingual inclines. Okay, they're huge. Okay, and the reason why is because there's no teeth on the other side to help with our guidance when those cusps move in that direction. There's no disclusion, so it's just tooth to tooth. And that's what guides the balancing movement, is those inclines right there. Okay, it's tooth guidance only. There is on this side nothing from the other side. So remember this interference here. I'm going to come back and show you this later. Okay, what happens to this in this case? So we made this crown with this quadrant with no tooth guidance on the balancing side, and we have this huge balancing interference we see right there. It's a nicely formed ridge coming down there. This has got some anatomy on it that's okay. This crown will chew pretty well, but we see this huge interference. And our thinking is we've got to eliminate that, okay? So we're going to grind that down because we see it. We're going to grind it down and we're going to flatten that tooth out, okay? Because there it is. But, you know, what a shame that is, because when we go back to the articulator and look, we actually have plenty of disclusion back there. When we put the other teeth back in and get these teeth to function like they should, we realize, oh my gosh, that didn't have to be eliminated. But I did, and I made that crown less nice. It chews less efficiently. It has less robust anatomy. It's not as nice, as much flatter tooth because of what I saw. And look in here. That interference that was huge, remember on the first bite I said we'll come back to this, it's way open. I mean, it's not even close to being an interference. But that one that we saw at 60 degrees, it's still there. Okay, so my guess is that in the patient's mouth, they really do have that balancing interference there. All right, but because we use a quadrant articulator, even on a quadrant model, even on a semi-adjustable articulator, we would have ground away part of our occlusal on our crown unnecessarily and flattened it and made it less pretty and less functional because we got the wrong information from our articulator. Remember what we saw when we did that. Okay, so the bottom line for me here is that anytime we have a case with more than 2 units, you know, in the posterior, you'll do a whole lot better with how they function if you use full arch models on an articulator. it's worth the time and effort to do this. You know, your outcomes will be so much better. You know, and you know, because this is the heartbreak of work that we do when we do a beautiful crown, and because we didn't understand, you know, how articulators work, when it got to the mouth, it was destroyed. And you know, we're heartbroken, the doctor's mad, the patient's mad at the doctor, and nobody's happy about a situation like this. And it's all avoidable when we see these things. And when we start putting quadrant models on hinge articulators or plastic articulators, because the condylar position is so non-anatomic, all these things get even magnified more than what we see when we put quadrants on a semi-adjustable articulator. Now, looking through this and looking at articulator selection, you know, as we go from fully adjustable to unmounted cast through semi-adjustable, non-adjustable, which are plastic, and unmounted cast, just hand-holding cast, you see that we get a whole lot more diagnostic information. We can see cants and tilts. We can correct problems that we can't do unless we have properly mounted models on an articulator. Okay, the information that the laboratory gets is way more. We've seen the function. I see way more accurate how teeth move across each other, how balancing interferences come into play, how to eliminate those. I can eliminate them. I can make everything more harmonious with the patient's mouth. Okay, the time and skill needed at the initial appointment is also more for the doctor, because he's got to take the records. If indeed we're correct in the occlusal plane, he's got to take me a Facebow. He's got to understand these things, take me full arch models, okay, study cast so I can mount these, analyze the occlusion, look for interferences, change the condylar guidance, whatever it is I need to do. You know, but chair time needed cementation, whoa, it's not even close. Okay, when you start to utilize these things correctly, understand what they do and take advantage of it. Does that mean you need an articulator on every case? No, you don't need a semi-adjustable, no. Single crowns in the posterior, single anteriors, you know, a couple of crowns. You know, you have to decide that by looking at the nature of a particular patient's occlusion. You know, we will quite often request full arch models and put a case on articulator when we see problems that the quadrant will present to us based on what we've learned here today, just an analysis of what's going on with the patient. Okay, so that one's huge. That really, that's what it all comes down to, is how well does these fit in the mouth consistently. How can we reduce the chair time adjustment, make the doctor happy, make the patient happy, make everybody happy, and make our pretty crowns stay pretty, okay? And so, you know, when should you select these articulators? You know, a fully adjustable, I don't really use them these days. I use semi-adjustables. I think they give us everything that we need. So, multiple opposing restorations, when I have no anterior guidance, extensive pathology, diagnostic assessment and treatment, you know, these things are when we always use semi-adjustable articulators. Okay, non-adjustables, which, you know, they call them large articulators. You know, the metal or the small hinges are for one maybe two posterior restorations, one maybe two anterior restorations. And unmounted cast, I never do this. Okay, it says only when occlusal influence is minimal. Okay, that means when there's no opposing occlusion. You got a crown with no opposing teeth. Okay, no function, no nothing. You know, just you don't have to mount it. Okay, and that happens sometimes. I got a case in the lab right now like that. But remember this, where the two main utilities of the articulator were functional movements and perceptual alignments. Okay, the articulator should be your friend. When you have casts properly mounted, the occlusal plane should be parallel to the base of that articulator. The midline should be parallel to that pin. And when we have these things defined with the way the models are in the articulator, we can control those things when we make the case. There's nothing worse than trying to make a straight case on tilted models. You can't do it. So we want to see that our study cast is indeed straight in the articulator, because we want to reproduce this in the patient's mouth. We can then do our wax up straight in the articulator. You know, exactly like the study cast. The articulator becomes our friend. The pin becomes our vertical. The base becomes our horizontal. And we do the crowns. Again, we have the same perceptual alignments from study cast to wax up, diagnostics, final crowns. So when this thing goes back to the mouth, guess what? This lady started out with a nice occlusal plane. We had no correction here. She had ugly teeth, but a nice occlusal plane. We put this on the mounting platform because I want to reproduce this plane. It follows her lip. It's really nice. We just want to enhance her shape a little bit, her form, but not the occlusal plane. So, you know, I put this thing on the articulator. It was straight. The crowns are straight. The study models are straight. Everything was straight. It went back to her mouth, and guess what? And her smile is straight. Okay? There was no surprise. Piece of cake, slam dunk, no problem, 100% confidence this case is going to go. Okay? So, to review these concepts that we talked about here today, when to use an articulator for anterior cases that involve cuspids in particular, or anything more than 3 anterior preps, or if any of the tooth that we're doing provide guidance and we need a guide table for this. Okay? For posterior cases, more than 2 consecutive teeth. We looked at the problems we can run into in lateral function with hinge or plastic articulators. And quadrants only for posterior support. Would we put those on a semi-adjustable articulator? Only if we're missing the tooth behind the prep and I want to make sure my vertical doesn't collapse. Okay, we need to use a Facebow when we're correcting occlusal plane issues, and that's about the only time. Except because remember, or if we're opening vertical, or unusual situations. Maybe somebody has been in a wreck and they're a little bit, they're just not straight, and we have to capture something that's not right. Okay, but remember, you can tweak a Facebow, but be careful when you do that. Okay, the mounting platform, is fine. It's great when no correction is necessary, when the occlusal plane is good, because it ensures good alignment in the articulator. It's what you want to do, and it's a lot easier to do. The important concepts I'd like you to take away from all this is that, anterior guidance separates the posterior teeth. Okay, it's captured with a guide table. Okay, if the prep tooth provides any guidance alone, you have to do this. Okay, you need a good study model to analyze the occlusion, eliminate the interferences, and make an accurate pantograph of the anteriors. The posterior guidance determines how much the teeth separate. The angle of that disclusion of the eminence in the posterior conjugal guidance determines how much teeth separate. Okay, you can determine the conjugal guidance with a protrusive bite, or just by looking, which is what we do. We function the articulator, we see if the balancing side is functioning, hitting. If it is, we increase guidance until they don't. It's really simple. Okay, we can eliminate those just by increasing the guidance. Again, which is why I like semi-adjustable articulators. And you must do this, eliminate these balancing and protrusive interferences first before we make a guide table. Why not? Why don't we eliminate working interferences? Because you can't. Remember, the working condyle doesn't move. It doesn't drop down. It just spins. It stays put. Okay, so the working side, the conjured guidance does not affect exclusion. It's purely done by the teeth, or the inclines of the teeth. And we always eliminate the balancing interferences with the lowest possible angle, okay, to make sure that we can bypass any potential interferences, if you remember seeing this diagram. Okay, now I'd like to talk about how to get the most out of your articulator, actually using it day to day in the laboratory. And how you can improve your results and your accuracy. And the things in particular that I want to talk about here are proper utilization of bites, how to mount properly and accurately, pre-spotting of casts to make sure that we have our vertical the same on the cast as it is in the patient's mouth, verifying our mountings and our function, and how to best control outcomes and get consistency in our cases so that case after case goes to the mouth with little, if any, adjustment, which is really what we want. Okay, and we do this by the use of aesthetic controls that come from the casts, and of course, how to get occlusion properly designed and adjusted. Now, bite trimming, I think, is critical. I'm going to spend a little time on this because it is probably the greatest source of high occlusion of anything we do in the laboratory. Okay, between improperly trimmed bites and improperly equilibrated casts. These are the biggest culprits. So when it comes to trimming posterior bites, which are actually the ones that are at greatest fault for creating problems in vertical dimension and mountings, you got to start by looking at your casts. And this right here is what I call the kiss of death. These little bubbles that are always in the occlusal grooves and fossa of posterior teeth, always. And so we want to use the cleidiscoid to take care of this and use it properly. We want to use the cleoid end and make sure it's sharp, okay, to remove the basic, get down to the basic anatomy and form of our fossa and remove the large bubbles. and make sure that we clean that out very nicely, following the contours of the molar, of the tooth. And then turn the instrument around and use the cleoid end to get into the grooves and make sure that those are clean and cleared out. And again, make sure you sharpen it. Okay, if you don't know how to sharpen a cleoid discoid, call me. I'll tell you how to sharpen them without ruining them. And then the next step, once we do that, is to pick up that bite and make sure that we remove all the little flimsy veins of material that represent the grooves, both on the occlusal surface and interproximally between the teeth. You can see here on between the molar and this bicuspid that the interproximal groove or vein of material is not removed. You want to do it like we did here on the distal behind that between the two molars. Make sure all those little bits are removed. Now here's a key. When you start to cut your bite, cut it right through the upper buccal cusps with a sharp instrument, making sure that you don't tear or destroy the bite because your instrument is dull. And then turn the bite over and cut through the lower lingual cusps. Okay? Because what you want to be able to do is see the cusp tips. Remember this, okay? Upper buccal, lower lingual. Say it over and over. This should be automatic. I'm going to cut through the upper buccal cusp tips, lower lingual. Over and over. Upper buccal, lower lingual. So you can see the cusp tips. If you've got the cusp hidden up in a bite, you can't tell that it's gone to place. It's really important to do this. So once we trim it through the upper buccal, lower lingual cusp, we removed all the secondary anatomy from the bite, we removed the bubbles from the teeth, we trial fit the bite. And don't push on it. Don't force or distort, because you can push on it with your finger and go, oh, that fits, and it doesn't fit. You're just distorting the bite. So make sure it fits passively. And when you look at this case, this is not good, okay? We failed to cut through the cusp tips here. So we can't see, the cusp tips aren't visible. I don't know that tip is fully seated up in that bite. It appears to fit the facial surface. Don't rely on that, okay? That will come back and bite you. You need to trim a little more off this bite. So once we put this bite on, we trial fit it. We want to see the cusp tips or incisal ledges in anterior as much as possible, okay, to know the bites fit first. And usually if there's a problem, it's not the bite, it's usually the model. So we look at this, what's going on here? Okay, there's an area that's not coming into place. What's the issue? Okay, when we go and look, something is distorted back there. Okay, I'm going to probably cut this off because my idea when I see this is that it's not usually the bite. It's almost always the model that's distorted. Bites traditionally are really quite accurate, okay, and the nature of the materials. They don't have any setting distortion. So we cut that molar off, and lo and behold, that area fits. It looks really nice. So I would make sure that on that second molar back there, nothing is touching, because I want to make sure that this comes all the way down and that distortion doesn't hold my models open slightly, that I suspect is on one of those second molars. Probably on the working model is my guess, because it was holding that distal buccal cusp open on that first molar on the working model. Remember that. We had that open thing. So yeah, I also like to keep a little bit of the bite on adjacent teeth at this point to make sure that I can verify that my models are accurate. If that bite fits down 3 or 4 teeth down, I'm probably pretty good to go for accurate occlusion on this case. Okay, it helps me to verify that they're accurate. And when I look at this bite, the second mnemonic I want to tell you about is, I call it tooth bite tooth. Okay, we want to see tooth followed by intimate contact with the bite, followed by another tooth with no space in between. So, you know, say to yourself, upper buccal, lower lingual, tooth bite tooth. And you know, it sounds silly, but I'll tell you, it'll keep you out of a lot of trouble. You know, no space between tooth to bite to tooth. Now here we look at this bite, we turn it over, look at the lingual, and we got a problem, you know, right there and a couple other places where we cannot see the cusp tips, okay? When you can't see the cusp tips, you can't verify the bite's down, you can't verify that your vertical's not open a little bit. And if your vertical's open a little bit, you're going to have a high crown. This is the greatest source of high crowns. You're going to make the crown too high. In the mouth, it's going to be in hyperocclusion. So when it comes to bites, though, in general, you know, don't keep more than you need. A bite like this for doing a single second molar crown is ridiculous. You know, there's no way you can make this fit in models. I see so many labs where they've got a bite like this just sitting on a model. They didn't trim the bubbles out of the occlusals. They didn't trim the bite. They just stuck the cast on there. Oh, it feels stable. They mount this case, and they got a crown that's so high that it's unbelievable. There is no way that this mesial portion of this bite can fit the adjacent teeth with the amount of distortion that's in this particular bite. So in this case, we're going to cut off just what we need from this bite. We're going to remove the grooves on the occlusal surface. We're going to cut through what? The upper buccal, the lower lingual cusps, okay, and we're going to trial fit this to place. And we're going to notice that it fits beautifully. It establishes our vertical exactly for this prep. And, you know, second molar is critical that we get the vertical right, because any slight change in or distortion of models makes a big difference in the mouth. And, you know, we want to, again, provide a crown that will need little, if any, adjusting. And again, tooth, bite, tooth. I see tooth, then bite, then tooth with no space in between. You see that? You're pretty good to go. When it comes to bites, don't use more than you need. Like I said, I will keep an additional amount of bites sometimes to verify my models, but then I'm quite likely to trim that down to just the area over the prep if it's a single tooth. Okay? If you don't need them, don't use them. Okay? At best, they will do nothing, and at worst, they'll hold the bite open. So in the case of a single crown like this, you know, I will trim the bites. I'll place them on there. I'll look and see how they fit each arch to verify the models are accurate. But when it comes to actually occluding or articulating with that bite, I won't. I'll remove it because it's not going to do me any good. I verify that my models are accurate, and that's all I really want to do if I don't need the bite. Again, if we don't trim our bites well, we can sometimes miss the fact that this bite was taken with an open occlusion. Okay, had I trimmed this bite back to just the prep and had not left any additional bite, I may have allowed this case to rock together and have an open vertical back on that crown back there. So it's very important that we, even if we decide we don't want to use it, we trial fit to make sure we don't have any issues. This particular bite left us with what we thought was a sufficient amount of clearance on this molar. In reality, we had almost no clearance. Okay, this doctor took this bite with the patient not fully closed. And had we not trimmed and looked, we may have missed this if we had just taken the portion of bite that was over that prep. Now, anterior bites, the same thing holds true. We want to cut through and see the incisal edges, okay, on the maxillary case. So we have to trim those bites through the incisal edges of the upper. Unfortunately, you know, well, and again, see tooth bite tooth. But as you can see here, we have to have overlap on the incisal edges of the lower. There is no way to trim that bite in order to see the lower incisal edges. That becomes, you have to have a leap of faith and understand that we can't avoid having a pocket that the incisal edge goes up into on the lowers. It's critical on these cases that we make sure that any bubbles or artifacts that are on those incisal edges in approximately in between those lower teeth are removed, both from the bite and from the model. So we're pretty confident that it will go down all the way. Now I'd like to talk about how to properly mount models into our articulator. Again, the Facebow versus the platform, how to use them appropriately, and upper versus lower, the differences in how we approach mounting depending on what we are mounting. Now, between the Facebow and the mounting platform, we discussed, you know, when to use these two things depending on the nature of the case, what we're trying to do. Again, use a Facebow if we have some correction to do, have occlusal plane issues. We need to capture a problem on the articulator so we can see it, so we can correct it. If there's no correction necessary because the occlusal plane is fine, we can go right with the mounting platform and eliminate the need for the Facebow. Now, when it comes to actually mounting our casts for typically our anterior case, we normally have three models to mount. We have an upper working model, a lower occluding model, and an upper study model. We have to get all those introduced into the articulator so they can be cross-mounted. Any pair can be put on and they will function properly and be properly mounted. And like I said, this is generally for a maxillary anterior case. Now, mounting the upper study model, this is sometimes kind of tricky because we have to get this right, you know, and we have choices between a platform or a Facebow, and again, it depends on if we're doing corrections or not. But why do we mount the upper study model to start and not the upper prep model? The reason why, and we should always ask our doctors if they're providing us with a Facebow to give us one of the temps or the pre-op, not the prepped model. The problem with preps is that when we look at them, they're not necessarily level. They're not cut to the same point. I can look at this and think, man, this is off. If I straightened this up because I thought it needed to be straight in the articulator, I would have it wrong. The molars are indeed in the proper alignment, but the anteriors, because they're all over the place, I can't tell what's straight. I cannot judge this mounting. So I always want to make sure that I put my study model on the Facebow. If I'm putting it on a platform, it will be level, okay? This allows me to look at this and verify that indeed the horizontal is horizontal and the vertical is vertical on this case. And that the midline is definitely behind the pen and that the horizontal is flat to the bottom of the Facebow, to the bar of the Facebow or the bottom of the articulator. So it's square in there. When I use the mounting platform, my occlusal plane is always straight to the articulator. This is the single biggest advantage of using this. It doesn't depend upon the abilities of the doctor to capture a proper Facebow, which, trust me, is not that easy. It's kind of a tricky thing to do sometimes to get it exactly right time after time. Now, in the case of a Facebow, we always want to make sure that we put the support in here, the Facebow support underneath the Facebow, because the weight of the model of the stone will distort that slightly. So use this thing. It's available. You probably have one. If you're not using it, do something to make sure you support that Facebow so it doesn't sag a little bit. And one source of potential inaccuracies when we're mounting is that people use too much stone. We want a small amount of stone here because stone does have some dimensional change. Even mounting stones have a little bit. They will expand just a little bit and they will actually move our cast just a touch. So we want to use a small amount of stone, let that set, and then come back and fill in underneath after the primary little bit of stone that attaches to the model sets, fill in and make it pretty. You know, go ahead and sandpaper it, make it look good. I'm telling you, you work on clean looking models, you're going to make clean looking case. Now, if indeed we have a case that uses the mounting platform, the process is exactly the same. We want to make sure that we use just a small amount of stone, get the initial attack, and then come back and clean it up by filling in around that model. Now, the biggest problem, though, in mounting inaccuracies comes when we're mounting the opposing. Here, if anything happens dimensionally with our mounting stone or whatever, since the upper is fixed, it's going to affect our occlusion. When we're mounting the upper, if we have a little bit of a discrepancy, it's not that big a deal because we're going to later come back and establish occlusion with the lower. So if it was in a slightly wrong place, slightly up or down, it's not going to matter from an occlusion point of view, you know, and probably very little from a function point of view. So this is where we run into some issues when it comes to mountings because we always have a large amount of space underneath these models, typically a large amount of space. So we want to do what's called a double mounting in most situations. And again, that amounts to being aware that stone has some dimensional change. We want to limit the amount of stone that we use. So we will put some stone on the bottom plate. Try not to get beyond the outside of it because we're going to come back later and neaten this up. Don't want extra stone to have to deal with. And get it up pretty close to the bottom of that model and let it set. Okay? Then come back with a brush and re-wet it, add some water to it, to that set stone. Okay, add the new stone, okay, fresh plaster, loosely mixed, and close into that. And so we accomplish our model with a small amount of stone, a small amount of dimensional change, and a much, much more accurate mounting. And we're done. At this point, we got our study cast mounted. We come back and mount the working model. And you know, I tend to use sticky wax to hold these together. Some people like burrs, and they like to not put the sticky wax on their teeth. That's a matter of personal preference. In cases like this, I put it directly on the teeth, a small amount of sticky wax. And you want to check your articulator before you do this. Make sure that you're at 30 degrees under conjugal guidance. Make sure that your conjugal lock is engaged, that you're eccentric, and go ahead and mount the upper. And again, we do it with a small amount of plaster to start with, keeping our dimensional change at a minimum, and then come back later and fill that in and make it pretty. And so we should now have casts that can be interchanged. We can put on the upper working model, we can put on the upper study model. They should both have the same occlusion to the lower, so we can now work with our case, make our aesthetic controls, make our guide table, do the things we need to do. And when we look at that cast, it should be perfectly aligned. The midline should be directly behind the pen. The horizontal plane should be exactly parallel to the tabletop and the base of the articulator. And now we will have no surprise. We can align our case. We can make our crown straight to these axes, to the vertical and the horizontal, and have a really nice case. And again, you know, we want to always verify that indeed the bite, when it's in place, shows us tooth by tooth. We can see the incised ledges perfectly, and we know that our mounting is indeed accurate. Okay, well now I would like to talk a little bit about how we can control our outcomes, improve our consistency and predictability, and make sure that case after case we deliver is of the same high quality standards as the one before, and give doctor hopefully something that he adjusts very little and everybody walks away happy. And a couple of things that will really help us accomplish this is, number one, what I call pre-spotting or pre-equilibrating the casts. And the posterior and the anterior, they're done slightly differently. And then talk about a set of controls, which I'm sure we're all familiar with. They are guide tables and putty matrices that help control what we're doing to reproduce the case the way we want to. Now, when we look at what happens typically, and high occlusion, over-adjusted occlusion is one thing that plagues all of us all the time. Why are crowns always high? And the reasons why is because everything we use in the process tends to increase vertical dimension. Okay, stones expand a little bit, so you ask yourself, is digital maybe better? Digital has some very interesting, brings a lot of interesting things to the table, because it doesn't. It's milled from an already solid piece of material, so we don't have that expansion we have with stones. There's also a downside to that because we don't have volumetric expansion, which helps us get passive fit. That's for another discussion. Okay, impressions change. Okay, there is some distortion or some dimensional change in impressions. Are digital impressions better in terms of dimensional accuracy? Probably so. Okay, these technologies are very, very intriguing and very interesting. On our models, dyes don't seat all the way. Okay, sometimes we ignore that. We don't really pay attention to any things that might be in around our dowel pins, or the fact that we see a tiny bit of space under a die. Some people, to avoid high occlusion, actually pick up their dies a little bit with some foil, and that just baffles me. How you can hope to be accurate doing something like that. Bites not fitting is a key ingredient of this. Okay, and a lot of times we're using the wrong type of marking tape for what we're doing in the laboratory. We should look at that and use something that gives us that works a little more within the accuracy range of what materials we're using. I'll talk about that later. And of course, all these things, the farther you go posterior, the worse it gets. We all know the second molars are adjusted a lot more than first molars, which are adjusted more than second bises, which are adjusted more than any tooth as we go forward. It becomes less and less. And there's a reason for that. It's called the Nutcracker effect, and we'll kind of look at that a little bit as we go on, right here. And kind of here's what's going on. When we take an articulator, semi-adjustable on the left, and let's say a hinge articulator on the right, and we put some kind of an interference or some kind of something that needs to be adjusted in the posterior, and we close on that, and it gets marked with a marking tape, and what it's doing is holding the casts open just a little bit. We can see the space, we can detect it with our marking tape. And if we look on a plastic articulator or a hinge, the opening is more in the front from the same size interference in the back. And the reason why is because where the hinge axis is, where the condyle is hinging from. But the fact that in a hinge or a plastic articulator, any kind of a discrepancy holds the articulator open more might be the one advantage of using these kinds of articulators, because it's easier to see if something still needs to be adjusted. It's easy to get the marks on the anterior teeth that show us that the posterior crowns aren't fully adjusted yet. So as much as I'm really not a big fan of plastic articulators, trust me, we use them. This is one area where they can really help us to find interferences or occlusal adjustments that still need to be done. When we talk about posterior cases, I want to use this example to kind of give an idea of what I'm talking about dimensional inaccuracies. In a perfect world, the teeth on our models will interdigitate all the way to the bottom. Cusps will go into fossas, fossas into cusps. Vertical dimension will come all the way down to where it is in the patient's mouth. But this never happens because our models are never perfectly accurate. Our bites are never perfectly accurate. So whenever there's a dimensional change and things are not quite where they're supposed to be, it always results in things in teeth and surfaces binding before they come all the way down to place, which always results in vertical being left open, okay? And this comes from impressions, it comes from stone, it comes from bites, it comes from anything we use, but the bottom line is things don't go all the way to place and we have open vertical. And this happens without fail on every case we mount. You can be guaranteed that if we don't recognize this and address it, we're going to have high crowns. So that's where pre-spotting comes in. We make an assumption here. We make an assumption that this patient has contact on all their teeth in the mouth. If they don't, they probably have some kind of issues associated with that they'll talk about, or the doctor will notice it when he looks at the patient's occlusion during his exam, and he will equilibrate them. We have to make an assumption that this was done. Now, when it comes to pre-spotting or equilibrating casts, we have some rules. Okay, one, clean out the artifacts. We talked about that on trimming bites, that we don't want any kind of artifacts on the occlusals, which are definitely going to hold them open and interfere with everything. Use the cleoid discoid when you're adjusting occlusion. A handpiece, or tempted to do it, handpieces are too aggressive. We're going to over adjust our casts and actually collapse our vertical and make shy crowns if we're not careful. Okay, in most cases, you adjust until the first unprepped tooth on either side of the crowns to be done or restorations has solid contact. Okay, now on full quadrants of prepped teeth, we don't pre-spot because bites, which are very accurate, will set the vertical. We can roll into the bite on the working side of that model and get a very accurate vertical. So when we got an entire quadrant of teeth prepped, we do not do the pre-spotting. And of course, on 4-arch cases, there's nothing to pre-spot much. So anyway, the process, I'm sure we've all done this. It's pretty simple. One of the keys that I like to point out is we should use tape that's a different color than the porcelain department, okay? So that in the model work department, we like to use green. So, what we do doesn't interfere, any marks on the model don't interfere with what the porcelain department is doing. So we tap with our green tape in the model work department, and we look to see what do we have, and we don't have contact, particularly on that cuspid right in front of this first bicuspid. So we start to equilibrate the cast with the cleoid discoid. We tap again, and we start to look, and sure enough, now I'm seeing a little something starting to come in on that distal marginal ridge, and I got a little something on the mesial marginal ridge there. And I look at this, and in my opinion, I'm never satisfied with these first marks that I get. I want to make sure I have really, really good, solid contact. So I will go ahead with my discoid and scrape away all these marks and all these teeth and go ahead and do it again. I like the fact that we got both marginal ridges on the cuspid, and I've got the mesial marginal ridge on the molar, at least that much. So I am going to adjust a little bit more on this cast, come back, tap again, and just get those marks a little bit stronger. Okay, I want to make sure that they're really good and firm and I got good solid contact. Okay, in these particular places, I'm really looking here. And always don't trust your marking tape. We can distort models. We can actually, if we put too much pressure, we can actually cause things to come into place and make contact. And we can get ghost markings. Take a look. Are my marginal ridges really in contact? Do I see that tooth is touching tooth here? And in this case, yeah, okay, I'm good. I like this. I can see right there that we're in contact in those spots. Now, on anterior cases, the rules are the same in a case like this. I want to pre-spot until I have good solid centric as far forward as I can get, and at least on the first tooth distal to my preps. So in this case, it would be the two cuspids. I'm doing 7 to 10 here. Now, on anterior cases, we want to make sure that we have our articulator set. Double check all this every time. Make sure your guidance is set to the right angle. Raise your pin slightly. People forget this. If you don't raise your pin, you can't bring down the vertical by equilibrating these casts. So you got to raise your pin a little bit and get it out of the way. Okay, and like a condyle, so you're indeed eccentric. We don't want to see any eccentric marks, not at this point. Okay, we want to make sure that we're working just eccentric. So lock that condyle. Again, we take our green tape, we tap, we take a look. What do we got? Well, right now we got nothing on these cuspids. Okay, so all our occlusion is back on those posterior teeth. And again, this is all caused by dimensional change between impressions, models, and a little bit on the bias, but mostly the impressions and the models. We're going to scrape away these marks with a sharp discoid, not a handpiece. Tap again, and look and see what we got. Didn't take much to start to get a nice contact here on this cuspid, but over there, got a little something, but I want to see something a little more forward. Okay, can I get a little more forward? And I can look in there and see if I should be anticipating something more forward. So again, I remove the marks that I got, tap again, and lo and behold, look at that. Okay, there we go. Now I've got some nice contact as far forward as I can get. I've brought my vertical down. I'm even seeing a little something up here in the incisal papilla area on the soft tissue that I want to take a look at. Okay, maybe I need to relieve that a little bit and make sure it doesn't interfere with my case. Are we done yet? Do you think we're done? Let's take a look. And look at that. I look in there and I realize, you know what? I can still get a contact way up on this mesial marginal ridge of this cuspid. I'm going to pre-spot this a little more until I see that contact come into place. I didn't pick up on it with my green tape looking at just the occlusals. So always take a look. Now, when it comes to helping control our outcomes and improve our predictability and consistency, one of the things we always want to use is a set of controls, and those are more having to do with predictability and making sure that we deliver a case that fits the mouth like we expect it to do and functions like we expect it. And of course, the two things we consider a set of controls are anterior guide tables and matrices. And of course, the anterior guide table, like we discussed, captures the lingual contours of the upper anterior teeth, and only if we're restoring some anterior teeth that provide guidance alone. Okay? It's not always true. This is another reason why we should always have a full arch study cast with any anterior case so we can go through the function on the articulator and make sure that the teeth we're going to be restoring, need a guide table, that they are alone at some point in the function, in the entire envelope of function, these teeth are providing the only anterior guidance. Then, boom, we need a guide table. So remember this, we talked about this before, eliminate your balancing interferences before you start. Got to make sure that your cuspid is indeed guiding, when you go into a working movement. You got to make sure that the posterior is disclude. You want to, make sure that you've eliminated all your balancing interferences. If those teeth are all separated, then you've got a balancing interference on the other side. You need to increase condylar guidance or sometimes adjust the casts to get rid of that balancing interference. Now, the guide table itself is pretty straightforward. Just a couple of things we make sure that we do every time when we do this is, make sure that we raise the pin slightly so that we don't go all the way down to the table underneath. Doesn't take much, just a little bit, a millimeter maybe. Raise the pin off the table. Vaseline everything from your fingers to the opposing teeth, the lower, to your incisal pin, to the linguals of your uppers. We want to make sure we Vaseline these because we don't want to wear them down and grind stone on stone when we're running our teeth through our movements. We want to not abrade the casts, and the Vaseline provides a lubricant that keeps that from happening. And again, on our fingers, we don't want the acrylic to stick to us. So we just mix our acrylic normally. We use paper cups and put it on the table when it's quite wet because I want it to stick to this table really well. But then patience is a virtue. Okay? Take your time, kind of feel it with your fingers, and wait until it doesn't stick to you anymore. Okay? Till you can touch it and it's kind of doughy and it's not sticking to your fingers. If you do this too soon, the acrylic has too much memory and your guide table will keep collapsing on you. It'll want to stick to your pin. It'll be a mess. Okay, so just take a breath and pause a little bit here. And when we're actually manipulating the articulator, go ahead and stop at useful positions. When you go into a lateral, have your eye on your cuspids and stop when your cuspids are in an end-to-end position. That way, when you're making your anterior crowns, when you push that pin in the guide table all the way to one side, your cuspids that you're making in porcelain should be end to end. That's where they should be. When you, on both sides, when you push the pin back and go into protrusion, stop when your incisors are end to end. Your facial surfaces are lined up. This way, when you're doing your porcelain, you can push that pin back to that back wall and look at your crowns and go, it's a quick visual check that I got my facial surfaces in the right place. Why not program this information in your guide table as long as you're making it? Why not? Okay, it just makes it a little bit more useful. Okay, and then of course after we create our lateral movements, our protrusive movements, we kind of go in little circles that our teeth scribe out all the little positions in between, called our mediotrusive or mediocentric. And then what we end up with is a really nice pantograph. It should be smooth down in there. And then the sides should be our cuspid and end positions. The back wall should be our anterior end-to-end or facial-to-facial position. And then all this other area is everything in between. And this whole area should be really smooth. If you've got grooves or channels or things in there, you missed some of you got to go back and start over. Okay? you missed some of your function. Okay, the last thing I really want to talk about is putty matrices, and everybody's familiar with these. They're just some things to keep in mind when you're utilizing these things, because there are two types of putty matrices. There's what I call the indexed, where the matrix is actually indexed on the lower model, okay, and it rides with the lower model. And there's an independent matrix, which is made just on the study model and transfers only to the working model. Again, we only make these for maxillary anterior cases, traditionally. In some tricky other cases we'll make them, but most commonly it's here. And so now the index matrix has some implications. It is dependent upon the mounting. It helps verify the mounting. It's needed when few or no unprepped teeth remain. The independent matrix is independent of the mounting. It can be less stable and less accurate, okay, but it's better for smaller cases, okay. And so when do we use these? And again, the independent matrix is also easier to use. When do we use these? We'll get to that in a second, but before you make your matrix, if you get a prescription and the doctor says, make some corrections, okay, please correct these temps in the finals, okay, you want to make sure that you do this diagnostically first. Go ahead and wax up those changes. Incorporate those in your matrix, incorporate those in your guide table. Make sure that you have everything you want in place before you start. Okay, now one nice thing about an index matrix is that it can verify your mountings. Okay, so we make the matrix on the study cast, and then we put in our working model and we take a look. How well do things fit? And we look at our posterior teeth, we look at the unprepped teeth. Do they indeed fit the impressions made from the study model when we put our working model into place? And if the answer is yes, we can be pretty confident about the interchangeability, the accuracy of the cross mountings between the study model and the working model. On the other hand, if we mount a cast, and again, this cast unfortunately got some glue slopped all over it, but the important information that we're looking for is that we have a problem, because when we put the working model in with the matrix index on the lower, it doesn't fit. What's wrong? Okay, we go back and take a look. So the first thing I do is put the study model back on again, and I mark some obvious anatomical landmarks that I can identify. In this case, it's an embrasure between a cuspid and a bicuspid, and I can find that on both models, and I mark where that line is on the lower. Okay, why do I do that? Because generally speaking, a study model that has no unprepared teeth on it tends to be accurately mounted, tends to be in MIP pretty consistently. So my first thought is the chances are it was the bite taken on the working model that's the problem. Okay, so now I put my working model into place and I look, and indeed those things do not line up. Okay, so I see I've got a discrepancy, at least anterior posteriorly, in some effect between these two models. Now I go back and put the bite back into the working model. Did we indeed mount this accurately? Is the working bite in the right place on the articulator when we close an eccentric? And I look and I go, yes. Okay, no, we didn't mess up with the utilization of the bite. It's accurate. Okay, so I verified my mounting, I verified my discrepancy. What do I look at? What happened here? So as I look at all this evidence and all this information, I start to get a feeling for what happened, because this mounting is fine. I feel pretty good about my study model. The bites in this mounting look good with the preps and the opposing model. Okay, so what happened to make this discrepancy between this corner that should be there? Okay, what happened was, remember, this index is on the lower. In order to get into this position, that lower needs to move back this way. Okay, we need to move the lower model back to the patient's right in order to bring this matrix in alignment with those teeth. What that means is that when the doctor took this bite, the patient was in slight left lateral. Okay, they had moved their jaw a little bit to the left, which means the right condyle had come down the eminence just a little bit and put us off to the side. Okay, and so we have to move that mandible back to the right slightly to make it line up on the articulator. What this means is we have to give the doctor a call, say, look, doc, The patient was in slight left lateral when your bite was taken. We saw this on the mountings. We need to get a new bite. And you saved the day, because if you had gone ahead and done this case, you would have had a disaster on your hand when you got back to the mouth. So we pick up on this, and we've managed to avoid a big problem. Now, again, on full arch cases, one of the problems we can have very easily is when a doctor takes a bite, he overcloses the patient. It's very difficult for them to stop at the right vertical when you have nothing but prepared teeth. There are some ways to avoid this. They can prepare some of the teeth, take a bite, prepare the rest, take a bite, but a lot of times this doesn't happen. So it's imperative that we double check our vertical when we're making our case. Always verify vertical dimension with calipers when you have full arch prep cases, no unprepared teeth in contact. And so we want to make sure that, here we're measuring the length of the central with our calipers. We're going back to our mounted case, and look, oh my gosh, I drew a red line on that lower model based on the study model where my incised ledge should come, and when I started this crown, I thought I was there. Look where I should be. How do I get the tip of that caliper to line up with that red line that's behind the incisor? In other words, I'll make a short incisor here. What I need to do is open that pin and open this vertical until my caliper touches that red line. My vertical is over closed. If I didn't pick up on this, I would have a disaster when I started to do this case. So this is really important to always, when you have no unprepared teeth left, always take calipers and double check. And I like to use a central incisor because that's the tooth that has the most vertical change as we change our incisal pin. Okay, so we have to increase our vertical dimension here. Now, remember this, where when we increase vertical dimension, we travel along an arc. Remember that when we increase it, we change the point at which we contact teeth. That plastic and semi-adjustable articulators move too far forward as they come down, as the jaw hinges. Semi-adjustable articulator, anatomic articulators move backwards more quickly. So when you're doing a case like this, you really need to be on a semi-adjustable articulator. Anticipate opening vertical when you're doing full arch cases. You will almost always do it. Now, to talk about the independent matrix, I want to talk about this a little bit. It's a very useful tool where we take a matrix just on a study model or a waxed up model. It's by far the easiest to use. Okay, it doesn't give us quite as much diagnostic information, and when you make it a little bit thick. Make it tall and a little bit skinny. Make it like an I-beam so it's stiff, so it doesn't want to flex a lot. So use a little bit of extra material to make it as stiff as you can by making it a little bit taller. And also index it really nicely onto your existing teeth so it transfers to the working model really firmly, and it has a firm index position on the unprepared teeth. So we can utilize this to be very handy. We can turn the model upside down. We can use it to guide us in our wax ups, to start our wax ups for our pressed ceramics or whatever we're doing. When I'm doing this, again, this came from either temporaries or from a quick diagnostic wax up. I don't concern myself with being exactly perfect in this matrix. I want to be in the ballpark, and I want to have my teeth the right length. And I may refine the aesthetics a little bit and the contours a little bit because I'm going to press these. These are going to be my crowns. I don't get too overly concerned. Now, the independent matrix brings into play certain things. You cannot verify mountings because, again, it does not index on the lower. It has nothing to do with the relationship between an upper study model and an upper working model. Okay, you need unprepared teeth to be able to use it, and sufficient unprepared teeth to hold it stable on the working model. And so it can be less stable. You got to be careful. They can collapse in the front and give you a false reading. You'll get the teeth the wrong length if you depend strictly upon an independent matrix when there's not enough unprepared teeth. And it is a whole lot easier to use though. Okay, whenever I can, this is my preferred way to capture the occlusal plane, incised ledge position, and buccal position or facial position of anterior teeth. Okay, I would like to talk just a little bit about designing and adjusting occlusion. Again, this is not meant to be an occlusion seminar. I just want to talk about some broad topics that kind of help get better results when we are designing and adjusting occlusion. When we talk about adjusting, whether it's on our wax patterns or on our actual crowns, I want you to keep some things in mind, and that is, in my opinion, Mylar is not the best choice. It's far too thin. Okay, it is way more accurate than the materials we're using. Remember, stones expand, mountings are off, bites get in the way, verticals are off a little bit. We're by no means in a world that is as precise and as perfect as what happens in the mouth. We want to be quite close, but we also want to be practical. So I think an articulating tape that's in the range of 60 to 80 microns thick is the ideal choice. It causes us to adjust things a touch more, and which in the mouth translates into more success in cases that require less adjustment, and this has borne itself out over years and years of doing this in my lab. Now, as far as anterior occlusion in particular goes, designing it, you should always look for marginal ridge contacts on your anterior teeth. You don't want to be having these middle of the fossa contacts, and your fossa should be hollow. It should be scooped out, and there should not be occlusion in there. So when we see occlusion in the middle portion of the fossa, almost always, sometimes teeth are malaligned, and no, this isn't so, but almost always we can eliminate those, hollow out the fossa, and limit ourselves to marginal ridge contacts in centric and in protrusion. Okay? Now, as far as posterior occlusion goes, we want to see really nice, precise point contacts, not bowl contacts as I call them. Okay? We want to see just nice, fine points of contact on our ridges rather than spreading our occlusion out over a broader area. The reason why is because this is much easier and faster for the doctor to adjust when he does have to adjust. You get much better mastication when you have this kind of anatomy, and it looks a lot nicer. Because keep in mind, when you have occlusion on the top of a ridge and the doctor needs to adjust, and what he's doing is basically dropping vertical and widening those contacts, the more narrow they are, the more narrow those ridges, the quicker and easier he can adjust vertical without having to grind a large area. And I say that in contrast to something like this where we have bowl contacts. And you can see for a doctor to adjust out a high contact that's this size, he's got to grind a big area to do it. And it requires a lot of removal of either tooth or porcelain. Okay? And it takes a lot longer time, as opposed to something like this where all he's got to do is spot touch these places and achieve the same result. So it looks nicer, functions better, it's easier for the doctor to adjust. And so we should always design our occlusal morphology around the idea of having these kinds of contacts remaining. Okay? So when we get to the mouth, the idea is that first tap tap, he ends up with just small little points of contact, and the hope is very little to adjust. Okay, like here. This is an actual case where I asked him to take the picture, and he was like, "Whoa!" And we want to see. I want to see no adjustment if at all possible. Now here, this is a telltale sign of heavy contact. So in this particular patient's mouth, he actually had some heavy contact on his ridge, and he'll probably want to adjust this a little bit. It was not our crown. Okay. Now, I like a large piece of articulating paper or tape so I can spot the entire occlusion. And just looking at this, look at these contact points. Is there anything on this that, if this is what you saw, that you would like to change? And I look at that. You see a little contact going on that buccal ridge. That's a little bit of a working interference, in the middle of that tooth. I'd get rid of that. That's right on the ridge of the first bicuspid. That would be eliminated. I look back here. I also see a working interference or a working guidance on that side. I would eliminate that off of the cuspid. No need. I want that to be transferred more anteriorly to the bicuspid, to the cuspid. And on here, I've got a little bit of contact in the middle of this tooth. If I could shift that to the edges, to the marginal ridges, I would do it. You can't always on a cuspid. It's a little bit different, but I would try to do that. Now, as far as utilizing articulators, to give us the best results all the time, we have to make sure that they stay accurate and they stay in tip-top shape. And besides, keep them lubricated and functioning properly for centric locks and things like that, we want to make sure that they are accurate, and this is very, very important. They are properly calibrated. And the old verification system that we had with Danar and Hanau involved a field inspection gauge. The Hanau one involved actually just feeling to see if casts were aligned on a split cast, and they were very inaccurate. Today, specifically with the Whitmix line of Danar and Hanau articulators, we have what we call No shit, I forgot. What's it called? The DNR verification gauge. We'll have to edit this out. Okay, we have the DNR verification gauge. And with this, you can transfer casts between articulators with confidence. And it's such a simple thing. It's just split casts that mount on the articulator, and there's a pin that drops through a hole, and if it drops through, your articulator is in alignment. If it doesn't, it needs to be either repaired or adjusted. And this little chart, I don't want to spend a lot of time on it, but it lists the various articulators that can be adjusted, that can be verified. If it marks green, you can verify that it is or is not accurate. And if it's in blue, it means you can verify and then adjust the articulator. So there are some articulators in the line you can adjust if they're off, others you would have to send in, but at least you can identify a problem with the alignment of your articulator. And for further information on this, go to the WebMix website and the webinars and check it out. There's a lot of information on how to do this properly on your articulator.